implementation of a new suite of training materials helping babies survive. So the purpose of our webinar today, I would just like to mention, first, we want to share lessons learned both globally and at country level, and in particular the country of Tanzania, from helping babies breathe. And then we'd like to present to you a brief introduction of the new suite of helping babies survive, which includes helping babies breathe, as well as new components, the essential care for every baby, and lastly, the essential care for small baby. And then our third objective is to share examples of the new Survive and Thrive GDA partnership, featuring the 100,000 Babies initiative to save lives in 3 countries. These 3 countries are Ethiopia, Nigeria, and India, and together they account for about 1/3 of the newborn deaths globally. So we see the new opportunity with this Survive and Thrive partnership as a pivotal moment to transition from helping babies breathe in our lessons learned into the opportunity to leverage those lessons and add to the suite of training materials so that we can effectively save 500,000 lives by the year 2020. The agenda, I'll briefly mention, and then I'll introduce the speakers. First, we are going to just go over the achievements of the lessons learned from HBB. The role of the private sector will be the second presentation. Thirdly, we'll be talking about some innovations in training methods for healthcare providers from this suite of new materials. We'll follow that with an example of the national scale-up of HBB in Tanzania. And then we'll end with a description of the new work under the Helping 100,000 Babies Survive, an example of the GDA partnership supporting efforts to save lives in the 3 countries that we just mentioned. Questions are welcome, but I'm not sure that we will have time to be able to answer questions. So what we encourage you to do is to please submit questions and comments, and then be able to, we will be able to answer those and respond in a format online to be posted later. So without further ado, our first speaker is Lily Koch. She's well known to all of us and is leading, has been the spearhead for the both of the GDAs, and is of course from USAID and has been a major leader in newborn health. And Lily will talk to us about the GDA experience.
Thank you, Steve, and welcome everybody. Thank you for joining us at this webinar. I would like to begin by describing the context in 2009. That was even before the Alliance came together. At the time in 2009, it was estimated that about 1 million newborns died every year because they were unable to breathe at birth. A paper authored by Steve Wall, who is our moderator today, and others in 2009 noted that basic newborn resuscitation may avert 30% of newborn deaths. And yet, only 1/8 of babies who needed resuscitation had access to it in 6 African countries, as you can see in this graph here on the slide. That then became our call to action in 2009. In 2010, we acted on that call. Several partners from the private sector, public sector, and NGOs came together and established the Helping Babies Breathe Alliance. Our vision was simple but bold: to achieve significant reduction in neonatal mortality due to birth asphyxia. So what did we do? The Alliance provided support at both global and country levels. At the global level, we engaged with WHO and ILCOR, that is International Liaison Committee on Resuscitation, and we developed innovative technologies that were appropriate for low resource settings. At the country level, our fundamental principle was to respect and foster country ownership and leadership. We worked hard to integrate HBB within national program systems. What did we achieve in 5 years? I believe we changed the global landscape for newborn resuscitation. We have introduced HBB in 77 countries, of which about 50 are led and coordinated by national governments. We have trained and equipped over 300,000 health providers. By increasing awareness that tackling birth asphyxia is highly feasible, we were able to increase political commitment in many countries. Our private sector partner, Lerdal, developed innovative technologies that were appropriate for our educational program and for low resource settings. Overall, we increased global demand, supply, and use of resuscitation equipment. We also improved access to services by training providers and equipping facilities. Here in this graph, we have data from 6 countries based on national surveys and program data. It shows that the HBB program in these countries have resulted in increased facility readiness and increased access to resuscitation. However, it also shows us that access is hampered by low coverage of facility delivery in many countries. We have improved provider capacity to resuscitate newborns. In this graph, we see that providers in 7 country program sites successfully resuscitated an average of 84% of babies that did not breathe spontaneously at birth. I want to note here that these are data from program sites and they're not national data. We saved lives. A study among 80,000 births in Tanzania showed that HBB reduced early neonatal mortality rate by 47% and stillbirth by 24%. And you will hear more about the Tanzania program later in this webinar. At a global level, we hope to have made a contribution to an overall reduction in deaths due to intrapartum related complications in the past 5 years. So what have we learned? An important lesson that we have learned is that public-private partnership is an effective strategy. Together, we have mobilized about $58 million in the past 5 years in cash and kind to support HBB. Our assets included our partners' networks, influence, and program platforms. These assets enabled us to better coordinate our work, to provide a strong advocacy voice, to shape the global market, and to stimulate innovation. We have learned that to achieve sustained impact, government leadership and ownership must be the driving force. We have also learned that health system strengthening must be at the core of our program support. And so, what is the way forward? We have talked about the work that the Helping Babies Breathe Alliance has achieved in the past 5 years. We know that to achieve significant neonatal mortality reduction, we must broaden our scope and address other causes of newborn death, and we must also address maternal mortality issues. So we have now merged Helping Babies Breathe to a bigger and broader alliance, public-private alliance, called Survive and Thrive. And as you can see here, our scope has broadened from newborn resuscitation. It has now included other causes of newborn death. We have integrated clinical and quality improvement skills. Quality improvement skills is just as important as clinical skills as we move forward. We hope to roll out with the support of governments a program called Helping Babies Survive, and we have subsumed Helping Babies Breathe within Helping Babies Survive, so that we are able to address all major causes of newborn death. We are also hopeful that we can roll out a program that is targeted towards maternal health, and that's called Helping Mothers Survive, to address major causes of maternal death. Thank you.
Thank you, Lily. I hope if you have questions or comments on this, you would please jot them down and send them to us. We may have time at the end for questions, but if not, we will, as I said, try to respond. Our next speaker is Tor Lerdal, who needs no introduction. The Global Development Alliance has been privileged to have the Lerdal Foundation. I apologize. I'm on the wrong slide. So our next speaker is going to be Susan Niermeyer, followed by Nalini Singhal. And both are pediatricians and neonatologists. Susan is at the University of Colorado, and Nalini is in Canada, and will be sharing with us innovations in training methods. The title is Demystification, Simplification, Simulation, and Quality Improvement.
Thank you, Steve. So Helping Babies Breathe was the first program in this suite of Helping Babies Survive initiatives. And we really were confronted with the challenge that in 2008-2009, resuscitation was viewed as intensive care. So how could resuscitation be extended to the grassroots level where mortality was highest? Really, we thought we need to demystify this, because really resuscitation is not intensive care. It relies on basic initial steps of drying, of keeping babies warm, of clearing the airway and helping them breathe. And so we sought to really simplify the resuscitation algorithm to what you see on the left as the action plan, and emphasize those key steps that truly are life-saving and life-preserving for every baby. Again, warmth, clearing the airway, helping them establish breathing. We eliminated many of the complicated steps of intubation, of use of oxygen, of delivery of medications and chest compressions, because the science tells us that the most effective steps that help the greatest proportion of babies to breathe are those early basic steps. And we also made a training program that really emphasizes delivery of skills, something that was very different for most areas in which this program has been introduced. With the help of the Lerdal group, there was a purpose-built neonatal simulator designed that actually breathes, has a heart rate, and cries. And not only learning materials, but also the clinical tools of bag and mask for ventilation and suction device for clearing the airway. So together with the knowledge and the skills, birth attendants were really empowered to change their performance and change the outcomes of their babies.
As we learned from Helping Babies Breathe, we've continued to evolve over the last 5 years. We recognized that training was much better if it was done as low dose, high frequency, and led to change of practice more than just offering it once. The action plans for all of the 3 programs, Helping Babies Breathe, Essential Care for Every Baby, and Essential Care for Small Babies, can be used as a framework for change. So the simple actions that are in the programs, for example, like taking the temperature, they can be monitored. And so these can be used for monitoring how people are doing. Our learner workbook from Helping Babies Breathe has changed and evolved to what we now call a provider guide. And that was because we think that a provider should have something that they can refer to and use. The provider guide can also be used to monitor improvements and outcomes. So we've included in it now what to monitor and what processes can be used for improvement. And lastly, what we've done is we've started education of families so that the families can support the care of their baby. And for this, we've designed, at least for the last 2 programs, a parent guide that the parents can use to offer care to their baby.
Thank you, Susan and Lini. Very clearly, these innovations are transformative, have already transformed the care of newborns not breathing, and have great promise for the future with other causes of neonatal mortality. We now turn to Tori Laerdal, who is head of Laerdal Global Health, and has been, as was noted, a major contributor in developing the tools that have enabled these programs to move forward, and who is still on the cutting edge of creating further innovations. So Tori will be describing the role of the private sector in international health.
Thank you very much, Steve, and hello everyone. Laerdal is one of 2 private partners in this Global Development Alliance, the other being Johnson & Johnson, and the latter is probably much more known than we are. So let me say a few words about that. But first, the motivation for private partners to take part in global health programs may be different. It may be directly mission-driven, either through a for-profit or a not-for-profit company, often referred to as social enterprise. It may be part of a corporation's social responsibility program, or it may be based on pure philanthropy. Laerdal has, since the establishment of modern life-saving techniques around 1960, been a leading provider of training mannequins and therapy equipment for use of these life-saving techniques. We have had the privilege of working closely with organizations like heart associations, Red Cross and others to take part in their activities in spreading first aid training and CPR training to various groups of the population. It has been estimated by the American Heart Association that this has helped train over 400 million lifesavers and saved an estimated 2 million lives by CPR. The experience over these decades has taught us that life-saving must be made simple to learn and remember. It has also taught us that the greatest opportunities for saving lives relate to day of birth, and that low-income countries need highly affordable and culturally fit products. This motivated us to establish in 2010 Lærdal Global Health, a not-for-profit company, to work closely with alliance partners and local stakeholders. So to us, this is primarily mission-driven and not a corporate responsibility or philanthropy. The results of this, as presented in the 5-year report launched today, is quite encouraging. We have seen that this GDA has helped to drive also the scale-up of essential life-saving commodities listed on the UN Commission list for such. And we have been able to distribute more than 70,000 neonatally newborn simulators and around 200,000 suction devices and resuscitation devices as part of this program. Additional products are now being developed to support the new programs that are being developed and established under the Helping Babies Survive umbrella. We believe that this has also helped us build a better company, and I think this graph that you see here could be of some relevance in the different categories of motivation for the private sector to take part in global health programs. What is typically the way to evaluate the performance of a commercial company would be by the financial results that you see in the two circles to the left. Namely revenue or sales and operating results. But in our case, we have a mission of helping save lives. And since these programs are so much related to the global health setting, we believe that the not-for-profit company, which is then represented by the yellow sector of these circles, is contributing very, very significantly to our mission achievement. You will see to the left that a not-for-profit company is not contributing to our operating results, but as you go to the right, it is contributing very significantly, not only to mission achievement, but also to factors like employee motivation and brand equity. So to us, helping babies breed is also helping us to build a better company, and we are very, very privileged to be part of this alliance. Thank you.
Thank you, Tori. Very clearly, the support and leadership of Lærdal has made a huge difference in moving us forward with first neonatal resuscitation, but now the additional interventions that are part of the Helping Babies Survive. We're going to turn now to an example of a country that has made tremendous progress and really, I think, serves as our model country for the rollout of Helping Babies Breathe in this case. We're very fortunate today to have Dr. Georgia Simo. She is the Acting Assistant Director of Reproductive and Child Health Services at the Ministry of Health and Social Services in Tanzania. She's been is the National HBB Program Manager and professionally she's a pediatrician. So she is able to give us insights into what has happened when Helping Babies Breathe has been introduced and gone to scale.
Thank you, Steve. I would like to share with you how Tanzania was involved in HBB, or Helping Babies Breathe. Actually, the program emanated from the demographic health survey of 2045 where the country noted that we were reducing the under 5 mortality, but not reducing the neonatal mortality. So in 2009, Tanzania was among the country which was privileged to test the AAP curriculum and using the LEDL's neonatal resuscitation tools, and we managed to have this program as owned by the government, and under the presidential commitment, because our president was declared that birth asphyxia is a priority intervention. So in that essence, we were able to have an operational plan on how can we reduce birth asphyxia. And it was through using that AAP training curriculum and using the tools we had. And we had 2 arms. First, we had a pilot or learning sites, 8 of them. And then we had another arm, which was just a dissemination or a scaling up of the neonatal resuscitation. And fortunately, from the pilot site or learning site, it was vivid that we were able to reduce early newborn mortality by 47% and reduce stillbirth by 24%. From that essence, through our national commitment, we were able also to equip the facility, the healthcare providers, and facilities with the resuscitation equipment. And we declared that Helping Babies Breathe training curriculum will be a national teaching methodology for newborn resuscitation. And we committed that we'll have a focal person to push the rollout from the central level. And all regions and districts were also committed to see that the interventions is being rolled out. So far, we have learned some lessons on how to do it. First of all, I have to thank partners, because the government, without working with partners, it could have been impossible. So we thank, because the program is fully supported by Children Investment Foundation Fund, and it was also supported by UNICEF regarding training of district trainers, zonal trainers, and also it was supported by WHO in terms of assisting to train a master trainer and the zonal trainers. USAID, whereby through supporting integration of HBB into their other program like emergency obstetric care, and later days of Saints Charities, which helped us to integrate or to train the pre-service curriculum. And also we are working together with JAPIGO to roll out the intervention. And also we have learned that for sustainability purposes, we need the districts actually to commit funds through their councils, health plans, to budget for the equipment for resuscitation, and also budget for refresher training for their skilled birth attendant. And in order for the sustainability to occur, because it is impossible to continue to do refresher training, we are embarking to train all pre-service tutors for sustainability and equipping them with simulators and neonatalia. And we also learned that the program can't work without having equipment or commodities in place. So the commodities were also procured by government, UN agencies, and partners. And we have moved from vertical program of HBB being vertical program, and we are integrating it in essential newborn care and the emergency obstetric care programs. And in order to have those providers having or adhere or attain the skills, we are also doing clinical coaching and mentoring activities. These are also a priority. But for further steps or next steps, we are working on developing policy, the new policy for continuous profession development. And also we are putting up a program for national clinical mentoring system. And in order to have a place to refer those babies who are resuscitated for further care, we are planning to have advanced care trainings in our referral centers. So those are some of the lessons learned so far. And we have observed that through our newborn resuscitation program in our country, the facility delivery, the facility readiness actually, and access has improved as it is being projected over this slide. If you compare when we introduced the HBB program, the number of staff which were trained in HBB increased from 2012 from 20% to 75%, and our facility were equipped from 21% in 2012 to 75%. So the facility are equipped with resuscitation equipment. Not all that, but at least the access is also improved from 10% to 38%. Here the challenge is, although the facility are well equipped, but the access is still limited. We expected that if we the facility are equipped by 75%, so even the access could improve to 75%. But the challenge is our facility delivery is still low. We are at 50%. So we have to work on demand creation to improve the access.
Thank you, Georgina. An exciting development in Tanzania, and again, a model for, I think, many countries to follow. We are now going to look ahead to what is a new program that is called 100,000 Babies, and it is a multi-partnered effort to support efforts in, as I said, 3 countries: Ethiopia, and India, and also Nigeria, using the suite of materials that are now available through Helping Babies Survive, working with government and with professional associations in those countries, providing technical assistance and building capacities. And you'll hear more about it because we have 2 speakers. First, we'll hear from Professor Bogali Worku from the Ethiopian Pediatrics Society, and then he will be followed by Dr. Naveen Thakur, who is with the Indian Academy of Pediatrics as the past president and is currently the president-elect for Asia Pacific Pediatric Association, and has been the coordinator of development for the International Pediatric Association. So please, Dr. Bogali.
Okay, thank you, Steve. Ethiopia, at the moment, there are several activities going on newborn health at primary health care level. This includes community-based newborn care, newborn corner initiative at health center level by training health workers and equipping health centers with basic resuscitative equipment. But we found out that there is a gap at hospital level where we don't have newborn corners and no skilled personnel, and basic equipments are lacking. Therefore, the Helping 100,000 Babies Survive and Thrive initiative has come up now to fill this gap. And this initiative has 2 major objectives, and one is to improve clinical competence and quality of care in 180 hospitals. So in the country, we selected 180 hospitals, and in these 180 hospitals, we will establish newborn corners, and this newborn corner obviously will be equipped with trained personnel and basic life resuscitative equipment. The plan is to train 4 midwives from each hospital, and also include 40 health teaching colleges where we plan to train 200 college tutors. Training is not only the only way of improving the quality, but we also are planned to conduct advocacy meeting for partners and professionals. And back to the training, we are planning to adopt the Helping Babies Breathe, essential care for every baby, and essential care for small babies developed by AAP into the Ethiopian situation, and use these materials for training. We also have a plan to strengthen quality improvement and support supervision and mentoring in these 180 hospitals that are selected by the government. The second main objective is to strengthen professional associations, which includes the Ethiopian Pediatric Society and the Ethiopian Midwifery Association. This will be training and updating members from both societies in advocacy, newborn health, and quality care. There will be also a twinning partnership between US and Ethiopian professional associations. We'll have twinning of hospitals, twinning of NICUs. There is also a plan to establish a committee of practice, and through these major objectives, we believe that there will be a huge impact on survival of newborn health in Ethiopia, together with the other activities in place. Thank you.
Hello everyone, I bring you greetings from Indian Academy of Pediatrics. HBS India project is being taken up with a goal to create a replicable model of immediate newborn care in support of India Newborn Action Plan. HBS India project will be implemented under guidance of Ministry of Health and Family Welfare by Indian Academy of Pediatrics in partnership with National Immunology Forum, FOXI, TNAI, SOMI, and other development partners. We are going to do pilot in 5 districts and then scale this up. We have done Indian adaptation of 2 modules of HBS, which we are going to implement as of now. That is HBB, Helping Babies Breathe, and ECEB, Essential Care for Every Baby. And it was done by an expert committee appointed by Ministry of Health. We have also now translated HBS material from these 2 modules into Hindi, and we are ready to do field testing of adopted material, and then we will go to pilot district. Our aim to have 1 person trained in resuscitation and essential newborn care present in every delivery in these districts. With our experience of NSSK, which we have trained more than 200,000 people in India, we have learned many lessons, and we are going to improve on areas which we with our experience. And these so in this program there is very strong component of quality improvement embedded in this model only, and also say a concept of low dose high frequency training drills and mentoring. And we will also be very closely monitor impact and improve upon whatever we have learned, because we have already a program in place for last 6 years. Thank you.
Thank you very much, Dr. We are at the end of our presentations at this point in time, and I think we have opportunity for questions, and I understand that there are questions that have come in. I think that I just want to say that in response to to kind of point out in response to the future endeavors with helping babies survive and especially the 100,000 babies initiative, I just want to point out for the participants in the webinar that that in addition to the approaches and training methodologies that were used for clinical training and HBB, we are in fact addressing what was learned to be a gap in HBB, and that is with quality improvement approaches and helping babies survive. So I just want to note that that is actually a new and I think a very important feature, just to call attention to that before we start questions. Ida, do we have questions?
Yes, we received a lot of questions. I'm trying to shift through the questions. We now have some feedback that the report on Healthy Newborn Network, the HBB report, should now be working. Fingers crossed. Please let me know if it's not working, and you should be able to download it and read the report. So I would like to actually start with Georgina. You have received 2 questions. One is around government commitment. How did you manage to get the President's attention and commitment to tackle birth asphyxia in Tanzania?
Thank you, Ida. Actually, Tanzania is a country which is privileged of having our President committed to see that the country attained MDG 4 and 5 by 2015. As His Excellency, he's a co-chair, was a co-chair with Prime Minister Hapa of Norway on Commission on Information and Accountability. So being a co-chair, he wishes to see that the country attained the goal for MDG 4 and 5. So that's how he became interested in the issue of newborn resuscitation, because the challenge was, in order to attain MDG 4, was to work hard on reducing neonatal mortality. And that's how he became interested to push the agenda of newborn health in the country. Thank you, Ida.
Good. And so what did you tell him or your group to convince him that it was resuscitation that he should focus on for newborns?
You know, when the training curriculum was ready in US, it happened that our president was also in US. So he met the group that was developing the training curriculum, and he was briefed on how it worked. So when the program was introduced in the country, he was already sensitized and knew that this program will work. So he was actually pushing us to see that we implement the program.
Very good.
Yeah.
We also received a question for Georgina regarding pre-service training. So have you managed to include this program in pre-service training in Tanzania?
Thank you, Ida. When we started, it was like we started with the in-service training. But we realized that there is a gap in pre-service. So we requested our counterpart, because in-service is in different section within the Ministry of Health. So we collaborated with our counterparts in the training section to be involved in the making sure that the training curriculum is incorporated within the pre-service curricula. So, and then as I was actually pushing the agenda of newborn resuscitation, I met another NGO, Later Days Saints Charities, who actually agreed to support the training of tutors in the pre-service. So that's how we are working with the pre-service. I know that the training section, they are doing with making sure that they are training tutors under the support of Later Days charities, and they are using the neonatal resuscitation from Elida's foundation group, and using the same training curriculum from AAP.
Very good. Then we received a question that this seems to be very focused on the facility. So what do we do with the close to 50% home births? So I would like Susan or Nalini to respond to that.
Thanks, Ida. We have just been discussing this, and truly to have impact at a country level, there are several strategies, and different countries are pursuing different strategies. Many countries are using improved service delivery in facility to attract patients to actually seek an attended birth. And so that has proven very successful in India, for example, and maybe Naveen would like to comment further on that. Sometimes it's a combination of improved service and financial incentives to the client that can really increase the proportion of in-facility births. So that's certainly one strategy. Another strategy is really to incorporate community health workers into the organized health system and use them as service delivery points for birth attendance and for neonatal resuscitation. That model has been used in Bangladesh, for example, and represents another alternative. And finally, these materials are quite simple, quite straightforward, pictorial, purposefully so they can be understood visually and very easily recalled as a mental framework. And in areas where there is no plan to extend health services, there isn't enough health capacity, it has been possible to train traditional midwives, community birth attendants using these materials.
Great. I also have another question for the two of you. It's in regards to, hold on, let me scroll down. You guys are sending in a lot of questions, thank you. By eliminating the more complicated steps like oxygen, and you've also eliminated chest compressions, do you find that the clinical effectiveness of the intervention remains high for most newborns?
The complicated steps were initially eliminated because the number of babies that need the complicated steps is very, very small. So less than 1% of the babies receive chest compressions in areas where chest compressions can be provided. And over the last 10 years or so, we've recognized that resuscitating with air is in most circumstances better than resuscitating with oxygen. And that's why the complicated steps are not included in the program. And in addition to that, then we see that the complicated steps really are not necessary because both from Bangladesh and from Tanzania, we've seen that babies that receive the basic steps are effectively resuscitated. That doesn't mean 100% of them would be, but the majority of them are.
So I think this question is for Lily. Can you tell us a little bit more about Survive and Thrive? When was it launched? How long it's been running for? Do you have any results to share?
Thank you for that question. Stepping back, Helping Babies Breathe Alliance was established in June 2010. And then in 2012, we established something much broader called Survive and Thrive. So there were two separate alliances with two different names, one focusing just on basic newborn resuscitation, and the other having a much broader mandate and was therefore called Survive and Thrive. And last year, around October, when we had our annual meeting, we decided to merge Helping Babies Breathe with Survive and Thrive. So we currently have one single alliance. And so what started with 5 founding partners under Helping Babies Breathe, we now currently have 18 partners under Survive and Thrive. In terms of results, yes, we were very pleased that we were able to share results of Helping Babies Breathe today with you. Survive and Thrive, since it's just started in 2012, we are still developing our program. We've I would say we've just completed our formative stage. We're very pleased that we were able to develop some additional training modules under Helping Babies Survive and new ones coming up under Helping Mothers Survive. So we hope that we'll be able to share results of those new modules and those new programs with you not too in the distant future from now. But at this point, it is hard to point out any sort of public health outcomes from Survive and Thrive. What we have established are, what we have developed are programs, training programs, which we are now launched, we are poised to launch them in many countries. We've had a couple of regional workshops in Africa and in Asia where we have begun to launch those new programs. Thank you.
Okay, we're getting bombarded with questions here, and we don't have so much time left. A question has been coming up a few times, and I was thinking, I don't know who should address this, maybe Lily again, but a lot of people are asking about funding, if there is funding available to roll out Helping Babies Breathe. I know this is a tricky question. I'm sorry to put you on the spot, Lily.
Like a very good bureaucrat, I will give you a very nuanced answer. You know, this is a public-private partnership. In USAID language, we call it Global Development Alliance, or GDA, where it's really a strategy to multiply resources from both the public and the private sector, and resources from all partners. So every partner who's a member of this alliance actually has to sign a memorandum of understanding or an addendum to an MOU describing what is their contribution. So everyone comes in as a resource partner. That is one of the principles of a Global Development Alliance, or a GDA. So having said that, as I had said in my presentation, we were able to mobilize almost $60 million for the program activities. Much of this money was actually from the country level. A lot of it was from USAID missions in countries who were already supporting governments to roll out their national programs, maternal newborn programs within those countries. And so we were able to integrate Helping Babies Breathe into existing programs. So that was one way of mobilizing resources from the USAID side. We also have private sector partners who are able to invest in the development of the curriculum, development of the equipment. So that was not hard cash available for free. It went into the development of products. But if we were to pay for that, that would have cost us a lot of money. So it came for free for the alliance in a way, because the private sector supported the development of that. There were, I think, very important to say that many of our partners may not have brought in cash, but they brought tremendous assets that, if you were to convert it into cash, would be a lot of money. And that is their volunteer time. Many of the NGOs who are partners in this alliance, American Academy of Pediatrics, other professional associations, volunteered their time, and we were able to convert that to a dollar value. The Latter-day Saint Charities as well have missionary couples all over the world, not just couples, missionary volunteers all over the world. We converted that as well into dollar value. So it was a combination of resources from all partners. And I'm going to stop there. I don't know if anybody else wants to respond to that question.
I think we need to move on to another question. Thank you, Lily. So, Tore, we're moving on to you. There is some feedback here that will Lärdal work on new mannequins because some of the ones that they have available are fragile and prone to break.
Well, we are sorry to hear if that should be the experience, but remember the first mannequins were produced some 6-7 years ago, so they do have some limit to the lifetime depending on how they are maintained. What I can say is that we have significantly improved and reinforced the production process of this so that our experience is very positive with the lifetime of what is now currently in production. And overall, I think we have a very good experience and feedback. There are, as I mentioned earlier, some 70,000 of these neonatally is in use. So it is, I think, to be expected that there could be a few of them that are not in working order any longer.
Yeah, thank you so much, Tora. There's also a question around new products for HBB. I think from Lärdal, I think we can address that online. We have received some questions around quality of training, and in India, how do you address the quality?
As I said, that we in HBS proposal, that was something missing in what training we were doing till now. But in HBS proposal, no doubt the quality of training conducted by us was very good, but it was not resulting in totally into clinical skills, so which is something more than training. Now in HBS, we have a very embedded component of quality improvement cycle, learning from SS project in India, and a component of mentoring, continuous mentoring. So we are going to take care of that. It's not possible to give all details in just, I think you have 1 minute left.
Yes, we do.
But we will take care of that, that's a promise.
We do have a lot of questions, and we will answer them and make them available, the answers, online. So this group will go through the questions and make sure that we have responded to them.
Thank you, Ida, and thank you very much for all those who have participated and sent in really provocative and important comments, and we look forward to addressing all that we can, and we'll certainly make the responses available. I call your attention to the online resources that are available through the Healthy Newborn Network and the Helping Babies Breathe website, and I believe this is on your screen. Just to note that the resources that are available are the Helping Babies Breathe report, Lessons Learned, Guiding the Way Forward. This is a 5-year report of the program. All of the webinar PowerPoint presentations will also be available. As I mentioned, the responses to the questions sent in during the webinar will be also included, and there is a recording of the HBB webinar for those who are interested, and we obviously would encourage you to share with others who may be interested and may not have been able to join. So we are going to officially close. I just want to first thank all of the participants here who have given their time and really have already established a tremendous leadership in moving forward the new opportunities at hand for newborn survival, and I think also for maternal survival. And we are indebted for the Lärdal Foundation for hosting this webinar, and we want to thank all of the participants. Please, if you do have comments, we welcome them. It's very clear that we're poised at this moment to transition from Helping Babies Breathe to Helping Babies Survive, and I think the opportunities at hand are are really amazing, and I look forward to working, all of us look forward to working with you in this partnership. Thank you very much.